Good afternoon, everybody, and welcome to today's President's Speaker Series. I'm Catherine Todd. I work as the Vice President for Systems Innovations and Programs with you all at AHS, and I really appreciate you joining during your lunch break. It's a great opportunity to use your brains while you eat. And I'd also like to thank our hosts here at the 7th Street Plaza and our telehealth folks who really help us set up these presentations. There's a lot of work that goes on behind the scenes to make sure that all of us who are AHS has this opportunity to learn from others, and so really appreciate you participating. Just so as you know, this event is being recorded, so if you're listening on a phone line, you'll be able to watch the full presentation at a later date, so it will be recorded and available to everyone. And today, for our lecture series, we're very excited to have Dr. John Lavis is our keynote speaker. This is a huge opportunity for us in AHS to learn about being a learning health organization. And John is the founder and director of the McMaster Health Forum, and his topic today, really important to all of us, is 10 lessons about creating rapid learning health systems in Canada. So we have a lot to learn about this. Just by way of setting the stage here, we'll have 15 minutes for questions and answers following John's presentation. And for those of you who are not joining us currently right here in person at 7th Street Plaza, you can email your questions to, I'll try and say this as slowly as I can so everybody can write it down, pss@ahs.ca. So we're looking forward to hearing all your questions and comments for John, and we'll answer as many of them as we can before we run out of time. So for the formal introduction, I'm going to turn it over to Dr. Ted Braun, our Vice President and Medical Director for Central and Southern Alberta. Ted is filling in for Dr. Verna Yu today. She really is apologetic. She wasn't able to be here for this lecture, but did have the opportunity to hear from John and talk with John at our ELT meeting this morning. So, Ted.
Thanks very much, Catherine, and good afternoon, everybody. So, as Catherine said, on behalf of Verna Yu, who's not able to make it today, I'd like to welcome all of you here to 7th Street Plaza in Edmonton, as well as those of you on some 40 sites across the province, and also acknowledge that those of us here in Edmonton are on Treaty 6 and Métis Region 4 territory, a traditional meeting place and home for many of our Indigenous peoples. I'd also like to welcome everyone joining us on those telehealth sites. It's great that we have that technology to bring everybody with us this afternoon. No matter where you're watching us from, you're in store for another outstanding presentation and discussion. As Catherine mentioned, the President's Speakers Series brings together our staff, our physicians, and international experts and innovators to discuss ideas, advancements, and strategies around healthcare. It's a chance for us to learn from other leading thinkers in health from across the globe and adapt their ideas to how we can continue to deliver care in Alberta. And on that note, I'm very excited to introduce Dr. John Lavis. I first learned to know John quite a number of years ago when I did an extra fellowship with the Canadian Health Services Research Foundation, what's now called the Canadian Foundation for Healthcare Improvement. And John was a passionate faculty member, and I remember well those sessions that he led, and was very appreciative of what I learned from him. John is the founder and the director of the McMaster Health Forum, which works to solve the pressing health system issues of our time by gathering and evaluating the best research evidence available, along with engaging stakeholders and the public. Dr. Lavis is also the co-chair of the World Health Organization-sponsored Evidence-Informed Policy Network Global Steering Group and a member of the World Health Organization's Eastern Mediterranean Region's Advisory Committee on Health Research. He received an MD from Queen's University, a Master's of Science from the London School of Economics, and then went on to do a PhD at Harvard in health policy. And as you can imagine, he's got quite the busy schedule, so I'm very grateful that John has agreed to join us today to share his thoughts and experiences. AHS and other health and research organizations are increasingly putting rapid learning and improvement at the top of their priority list, and it's easy to see why. Organizations that adopt a rapid learning approach have potential to drive quality improvement that's informed by data and evidence, to improve collaboration and connection between research and direct patient care, and to improve patient experience and outcomes. AHS has been focused on evolving into a rapid learning health system for many years now, and indications are that we are making progress. Last December, McMaster University, under John's leadership, released a report on creating rapid learning health systems in Canada. And in this report, they mentioned AHS advisory councils and our strategic clinical networks as excellent examples of how to improve patient outcomes and experiences, to enable data and evidence-informed transformation at all levels of the health system, and also to motivate greater collaboration amongst all elements of a research system and a healthcare system, and better leverage quality improvement in learning systems. SCNs were also mentioned in a 2015 report commissioned by the Federal Health Minister, at the time, the Honourable Minister Rona Ambrose, entitled Unleashing Innovation, Excellent Healthcare for Canada. The report touts SCNs as bottom-up networks that foster interprofessional and clinical and academic collaboration to meet the specialized needs of patients, both upstream and downstream. As AHS prepares to celebrate our 10th anniversary in April, it just seems like 7 years. It's gone so quickly. Our 10th anniversary in April, we're recognizing our successes as one of the world's leading integrated health systems, but we're also reflecting on our challenges to see how we can continue to improve the care for those we serve in Alberta. This includes looking at what other health care providers and systems are doing, which is why we seek out learning opportunities such as this. It's my hope that we'll be coming away from today with some fresh ideas on how to adapt our rapid learning approach to continue to improve patient experiences and outcomes. And on that note, without further ado, I'd like to welcome John.
Thanks very much, Ted, and thank you, Catherine. This work that I'm going to be describing, we did it over a very, very quick time frame, and there was a team of 6 of us that did it, and I picked Alberta and one other province, and I picked Alberta because I was intrigued by everything going on, and our team spends a lot of time studying Canadian health systems and health systems in other countries, and Alberta had attracted my attention for a long time. And the interesting thing was that I came out of the process being even more envious than I went in. I think if you live here, you sometimes don't stand back and realize the assets that you have here in the province and the way they're being joined up to actually drive improvements in patient experiences and care. So it's a thrill for me to be here, hear from people firsthand about what it's like. I know everything's not perfect. It isn't in any other health system, but it's perhaps less imperfect here than it is certainly in the province that I'm from. Disclosures, no affiliations with commercial organizations. This work that I'm going to be talking about was funded by CIHR and the Canadian Health Services and Policy Research Alliance. And it was guided by a working group that had a number of superb people from across Canada, including Verna Yu on it, who was very, very helpful. So no conflicts of interest that I can think of that would influence how I present this material. What I'm going to do is just talk about this concept of a rapid learning health system. It's the only concept that I've come across in the 22 years since I came back from my PhD studies that finds a place for everybody that I work with, the data folks, the senior policy officials, the HTA people, the patient and family representatives. And so I actually think it's an incredibly powerful way to be moving forward in terms of how we describe what we do. I'm going to talk briefly about some key success factors and point you to a report that identifies many existing assets in Alberta that can be leveraged and identifies a very small number of gaps, but also opportunities for better connections. So if you Google that language, rapid synthesis, creating rapid learning health systems in Canada, it should pop up. You'll see an array of PDFs. One of them is the Alberta Appendix, where you'll see all of the assets that we identified in Alberta, of which there are many. The questions addressed, so this group wanted to know what are the assets and gaps in each of our 10 provincial health systems, our 3 territorial, and that kind of ill-defined national level we have. We called it national/pan-Canadian/federal. National, because we have some things that are national. Pan-Canadians, because there's times where the provinces and territories work together. Federal, because the feds have jurisdictional responsibility for some aspects of care for Indigenous peoples, for federal prisoners, and for our veterans and people in the armed services. We looked at the health system as a whole. We drilled down into primary care, which Ted knows very well, and we also drilled down into aging or the elderly population. So when you look at the Alberta appendix, you'll see 3 tables, one for each of those 3. Second question we asked was, where have the strong connections been made among assets? Because you can have fantastic assets, but if they're not being pulled together to drive rapid learning and improvement, then it's a waste of time. Third, we asked what regions, sectors, conditions, treatments, and populations have been the focus or will be the focus of sustained efforts. So Alberta has had 16 strategic clinical networks. Think of those as 16 examples of this type of area of focus. One of the other things that came up in our interviews where Alberta's done particularly well is emergency disaster management. Each disaster you have had in this province, the health system response keeps getting more robust, and that's part of what rapid learning and improvement is about. What windows of opportunity can be capitalized on or created to stimulate the development and consolidation of these types of systems? And then, are there any arguments for pan-Canadian collaboration in an area like health, where it's really at the provincial level where the responsibility lies? Is there an argument for pan-Canadian collaboration? We think there might be, but it's in areas where there are strong interdependencies between provinces or some issue-based commonalities. So we had originally done a very exhaustive evidence search on rapid learning health systems for some work we did specific to Ontario. So for this national work, we updated those evidence searches. We looked at all 14 jurisdictions and their websites and documents in particular. We interviewed 50 key informants from across the country, sent out the tables to many people, got feedback on them, and sent out the draft report to 3 merit reviewers. So these are the top 10 lessons, and I typically have 1 slide per lesson. So I'm going to go through each of them in turn. You'll see 2 of them are highlighted in blue. What really matters is how well the assets are connected, and a rapid learning system framework offers the potential to get us farther, faster together. So if I only had 2 things to tell you, those would be the 2 most important lessons. But I'm going to talk about each of them in turn. So the first thing is the definition. What is it? So we ended up defining it as the combination of a health system and a research system that at all levels, and so here we're talking about that individual patient and family level, the self-management or care side, the professional encounter, the program organization, the zone or AHS-wide, and government. So it's all of those levels, and then it's across all parts of the system. So if you move from sectors like home and community care, primary care, and so on, to conditions, cancer, for example, treatments like prescription drugs, populations like Indigenous peoples. So then for those areas, it has 7 characteristics. So first is it's anchored on patient need, perspectives, and aspirations. So the language we use here, patients and families are telling us what dials matter and where to set the needle for what we're trying to change. So in our last discussion, we talked about Alberta's done amazing things in areas like co-design and so on, but very often the problem's been framed, the particular program's already selected, people are already thinking about implementation, and patients are being involved in designing the program. This is about stepping back and saying, what if you actually ask patients, what's the dial and where do we want that needle set? So if we want to, another example that came up this morning was with crystal meth. For folks that are living with substance use and substance use problems, in the area of crystal meth, what is it that they most want to see change? What areas do they most want to see action taken? Second, driven by timely data. Third, driven by timely evidence. Fourth, supported by appropriate decision supports, and there's a number of people in the room that provide those decision supports across the system. Fifth, aligned governance, financial, and delivery arrangements. So whatever's happening, who can make what decisions, how money flows, and how we organize care, all of them are designed to try and support rapid learning and improvement, and it's enabled with a culture of and competencies for rapid learning and improvement. So in each of those 7 areas, we have the definition, we have the prompts, and we ask the question, where for each province or territory are the assets, and then later, how are they joined up? So this is an example of a characteristic: digital capture, linkage, timely sharing of relevant data. Alberta has huge hugely important data assets. They continue to get better. You'll soon have Connect Care in Edmonton, then that will roll out across the province. You'll soon have more interoperability with primary care charts. Big improvements on this front. But what really matters is, can we harness those data and feed them out to patients and families, to frontline providers, to people in organizations, to different sites, to people across the system in ways that directly inform their decision making. So we have a set of prompts that we looked for. Again, Alberta has many, many of them, but perhaps one of the areas where we can go even farther faster in Alberta is by trying to harness that information and make it usable for people in their decision making at all levels. Another piece about that definition is where the original IOM conception comes in. So the original rapid learning systems thinking comes from the Institute of Medicine. They talked about 6 phases: identifying problems, designing care and evaluation based on evidence and data generated locally, implementing the plan and pilot and control settings, evaluating to identify what doesn't work, adjusting with continuous improvement, and using the results to drive care across the system. So that's the kind of rapid learning and improvement cycle, but I'm focused more on the assets that you draw on when you're trying to do that type of work, and I think there's analogs at the patient level and up at the higher government level. But when we talk about rapid learning and improvement, that's the way it was originally conceived. Second message that we drew out of this is that the research literature doesn't provide a recipe, but single studies point to key factors or strategies. One of the key lessons that we learned, which Alberta has been at the forefront of for a long time, is the importance of the engagement of frontline clinicians. Most provinces and territories do not have well-established engagement mechanisms like Alberta's strategic clinical networks. When we look at the literature on rapid learning and then we look across the country, we can't find many better examples of this type of stuff than strategic clinical networks. So what many of us are struggling with is how do we think about the appropriate way of introducing them in other provinces and territories like Ontario. 2 other observations. One I've alluded to already. There's often a lot of assets that are out there, some of which get more attention than others. But what really matters is how those assets are connected in particular contexts to drive learning and improvement. Another observation is about ethical issues, people being uncertain about where does research end and kind of QI or rapid learning and improvement. And Alberta's been doing a lot of innovative work on ethical review and is, I think, further along probably in sorting this out than most jurisdictions, certainly than the one that I currently live in. 3, documenting assets and gaps isn't rocket science, but it needs specificity and regular updating. So I mentioned before, we did this review in a couple of months. We looked across 14 systems. For each one, we prepared 3 tables. If you're interested in our take on Alberta's many assets, I would suggest you look at the appendix for Alberta, and you'll find 3 tables there, one for the Alberta health system as a whole, one that covers the primary care sector as one of 6 sectors, and one that covers the elderly. And in each area, we look to see, using those prompts, how is Alberta doing in those characteristics. And as I've alluded to before, many more assets in this province typically than exist in virtually any other provincial or territorial health system. And as I'll come to, more efforts to draw connections among them. A quick message, though, at the bottom, which is a little bit hard to read with the icons, is I don't think we'll have a rapid learning system in any given jurisdiction. We're going to have many. We're going to have rapid learning primary care systems. We're going to have rapid learning prescription drug systems. We're going to have rapid learning systems that support people with substance use problems. So while we talk about a rapid learning system, the reality is there are many, and they're going to need to be speaking to one another. And you would know that well from your experience with the 16 strategic clinical networks. 4, the list of assets is remarkably rich, even in small jurisdictions, but there are some common gaps. I've talked about the patient one. So my sense is Alberta, again, very far ahead in the rich number of patient and family advisory groups that you have. You have them at the zone level with geographical, or you have geographically focused ones. You have ones focused on particular populations. You have them for the system as a whole. Most other jurisdictions don't have that. But the question is, are they actually meaningfully engaged in saying, this is the dial we care about, this is where we want to move the needle over this time frame? Second, data about patient experiences often aren't being linked and shared in a timely way, and a lot of people very focused on that obsession with let's get the electronic health record up and running. Connect Care, very important, but once it's operating, that and Dimer and other things, the big focus has to turn to how do we harness those data and turn it into usable information at the front line, for whether it's patients and families, providers, or others. 6, culture of rapid learning and improvement isn't yet widespread across levels and areas of focus, probably less of an issue in Alberta than others. One question that comes up a lot, what is rapid? As I just said at a meeting we just had, it's faster than glacial, and it probably looks different depending on where you are. So if it's government, we get often big structural reforms every 5-10 years, new governments, new leaders, but government also needs to be much quicker at the incremental changes that help frontline care delivery improve. So at the policy level, sometimes people don't talk about rapid learning and improvement, they talk about radical incrementalism. Government needs to be much quicker to make the alignments in the governance, financial, and delivery arrangements to drive those frontline improvements. Finally, competencies in data analytics and implementation science may not be sufficiently well distributed to support rapid learning and improvement across levels and across areas of focus. So this is a province with incredibly rich expertise in data and analytics and implementation science, but the question is, can people in primary care networks and other places access those assets and use them in real time to drive improvements? And if not, then maybe that's the direction the system needs to move. People can't all be centralized. There needs to be this distributed capacity. 5, lesson 5, what really matters is how well the assets are connected to enable rapid learning and improvement. So when we were looking across the country at good examples, we could have picked, there were 3 on the short list for Alberta. The one we ended up picking was the approach to trying to make improvements for the elderly population in Alberta. And I think one of the reasons that it attracted our attention was that was an instance of you had the strategic clinical network and you had the provincial program, and they each have their strengths. And the provincial program has particularly strong links to the zones and into Alberta Health. So that combination of the competencies in the strategic clinical network, the networks and so on available through the provincial program seem to be able to drive improvements in a very powerful way that might not always be possible. So I'm going to skip this because it's hard to see. I'm just going to say that we have these figures. On the far left column are the 7 characteristics of rapid learning. The first 2 lower dots are the strategic clinical network and the seniors program. And what we talk about in that particular example is how they knit together the assets at all 7 levels to drive rapid learning and improvement. And that's the type of connecting up that we think is very, very important. Lesson 6 was some areas have been or will be the focus of sustained efforts to create rapid learning. It's really easy to identify these in Alberta because you've got the 16 SCNs, but you've also had the emergency disaster management. You have this experience with picking priority areas and saying, how are we going to keep improving? Some of the areas that came up across Canada as being almost Canadian-wide shared areas of interest for this are home and community care, and you have an initiative called Enhancing Care in the Community. Focus on particular populations. Of course, our work with Indigenous peoples has to be led by them, done on their terms, but that's a potential area if it was of interest to them to move in this direction. Many categories of conditions, big interests in trying to up our game dramatically across Canada in terms of helping people with mental health and substance use problems, and then in some provinces a big focus on certain categories of treatment. So Alberta has its 16 areas, it has emergency disaster management in other areas. Is there a need for other areas of focus, or is that the right mix for you? 7 interdependencies and issue-based commonalities. If we're going to collaborate on rapid learning systems across Canada, we need strong arguments because the real action in health happens primarily at the level of provinces and territories. When we interviewed people, they said, you know, we can think of two interdependencies that make the case for collaboration. So one is the planned strategy on patient-oriented research national data platform. So Kim McGrail and colleagues at UBC, in partnership with investigators here in Alberta and every province and territory, have signed on to this national data platform. In the coming years, you're going to be able to say, we have this issue in Alberta, and it's playing out in a particular way. What does this look like when we compare Alberta to all the other provinces? So there's going to be this increasingly rich national data platform that will permit benchmarking, evaluation of natural experiments, and so on. Another area of interdependency people pointed to were shared specialty care arrangements across jurisdictions. You'd be very used to this with your Northern Territory partners, and with Saskatchewan, you often have agreements about how you deal with specialty care at your borders. Some of the issue-based commonalities that people said would be good for pan-Canadian collaboration: care for mental health and addictions, which I've alluded to, care in rural and remote communities. Care in those environments is very different from urban, and Northern Ontario probably shares more with rural and remote Alberta than it shares with any part of Southern Ontario. And the need to develop accreditation and standards and other supports for rapid learning organizations and systems. So we talked in the previous session about how accreditation is key. We don't have accreditation standards for units, organizations, and so on that are focused on rapid learning. How do we know what they should look like? How do we engage people in a discussion about how they can up their game? 8 is the need to capitalize on windows of opportunity when they open. For me, the two big things that are happening right now in Canada that are critical are the reconfiguring of the Pan-Canadian Health Organization. So this is CADTH, Canadian Agency for Drugs and Therapeutics in Healthcare, Canada Health Infoway, Canadian Foundation for Healthcare Improvement, those big players that provinces like Alberta and Ontario do and don't always play well together, and they do or don't meet our local needs in our own jurisdictions. If we don't bake in the idea of rapid learning and improvement into those organizations and make sure that they're designed in ways that serve your provincial needs, it's going to be a lost opportunity for 10 or 20 years, because once those institutions get reconfigured, they will be stuck in that configuration for a very long time. Second example would be CIHR going through a new strategic planning process. We need lots of investigator-driven research in this country, but if we don't have a big chunk of our research funded federally that is meeting our provincial and territorial needs, we're going to be the weaker for it, and provinces like Alberta and Ontario are going to have to fund all their own research that drives rapid learning and improvement. Some of the other reasons why I think the momentum is there for consolidating and move in this direction: growing use of the framework across the country, growing role of patient and family advisors who are tired of sitting there having issues framed for them and just giving input. They are increasingly going to be pushing for change in areas that matter to them. Growing capacity for responsive and timely health systems research. You'll laugh about the fact that we're finally there in Ontario with our amalgamation of our regional health authorities, but we finally got there 10 years after you, and probably we're making big mistakes along the way, like not getting rid of our hospital boards, but you're 10 years into this process. And on the next point, if your next election doesn't fundamentally disrupt you, if the next government is willing to make functional minor improvements in things rather than look at another major structural change, you are so far ahead of other provinces and territories in this space that you can really look at consolidation and even more dramatic impacts on patients and families. And finally, not sure where it's going, but there are the discussions about national pharmacare. That can be done in ways that are highly conducive to rapid learning and improvement and appropriate prescribing, or it can be done in ways that aren't helpful. And again, if we don't bake it in from the beginning, if it were ever to happen, we're going to lose the opportunity for 10 or 20 years. Lesson 9, almost there. Rapid Learning Systems Framework offers the potential to get us farther, faster together. I said before, this is the first time in 22 years of work on health systems that I've found something that everybody I work with sees themselves in. And for me, the question is, how do we figure out how to row in the same direction? How do we play to our comparative advantages in ways that make sense? So I think rapid learning systems can enable data and evidence-informed transformations at all levels and in all parts of the system. I think it can motivate greater collaboration among all elements of the system. And I think it can better leverage any QI and other infrastructure that we have. So to me, this is a way of making even better use of our assets and having even bigger impacts than we're having now. This is just a quick slide, and it's focused on the evidence supply side. But I work in that second to lowest row. My focus is, how do we organize ourselves to get the right care to people? And I'm interested in understanding problems and their causes, because in my world, the problems are contested. It's not like we know that we have to keep making decisions about new technology. In my world, the struggle is one day, how do we improve care for people with this condition? The next moment is, should we get rid of the 29 regulatory bodies and do something different? We're moving between these very complex health system issues on a regular basis. But I've come to realize that we're very good at a certain number of things. But there are data analytics folks that are hugely helpful at the front and back end of working through an issue, the problem and the monitoring implementation piece. Guidelines and technology assessment folks are really helpful when we're focused on program services and products, respectively. We need modeling folks who can model what is this going to look like when we roll it out through the system. We need the implementation researchers to drive that change. We need the evaluation people, the trialists, but also many other people evaluating whether we're having an impact. All of those groups on the evidence supply side should be rowing in the directions that are set by patients and families and that organizations like AHS are trying to move towards. And I think what rapid learning frameworks or thinking does is help you see them and how they can play to their comparative advantages. 10, what you call it and who you engage will vary by context. We just talked about how point of care in Alberta, people think immediately more about point of care testing. So maybe it's driving frontline care improvements that matter to patients and that are based on the best available data and evidence. So we have been very helpfully advised by our public servant colleagues in Ontario not to use the jargon of rapid learning. It does not resonate with our current premier. Whereas if we use language about driving point of care improvements that matter to patients and that are based on the best data and evidence, we get traction. So with any given government, with any given leaders, you have to find the language that works for them. And in any given organization, you might have staff that have different names to their group, but they're hugely helpful in this group. So in Ontario hospitals, we have this jargon, business intelligence, clinical informatics, decision support. Sometimes those things mean different things in different hospitals even, but they're all potentially part of the solution. But a big challenge is the traditional lack of these types of staff in many parts of the system, and especially in parts like home and community care and primary care. And a big challenge for us is try to figure out how do we get that capacity for the data analysis, for the presentation of the data, for the rapid learning and improvement in ways that are distributed across the system. So those are the 10 lessons I mentioned before. 2 of them are particularly important for me. What really matters is how well the assets are connected. And Alberta has with its SCNs, and it has in the areas where the SCNs overlap with provincial programs, 2 particularly powerful examples of mechanisms that join up assets that many other provinces, like my own, wish we had. And the Rapid Learning Systems Framework offers the potential to get us farther, faster together. I think we have huge amounts of things going for us. We're not using everything optimally. We're not playing to our comparative advantage, and we can get farther, faster if we work together on this stuff. So some next steps at the forum, the report's sitting there. The Alberta appendix can be downloaded. As I mentioned before, you'll find tables for the system as a whole, primary care and elderly. We have some other work going on in different jurisdictions to try and move this forward. And if you're paying attention to the national level, I would watch the Canadian Health Services and Policy Research Alliance, because they're specifically working with key players, including Verna here in Alberta, for the cross-Canada dialogue about how we can do this better. So that's the slides. I tried to go relatively quickly so we had even more time for questions. So I'll open it to questions.
Thanks very much, John. So just a reminder for those of you at the remote sites, you can submit your questions to Sean Woods sitting in the front here at 7th Street by emailing them to pss@hs.ca. And Sean's going to read those out loud for us. But we'll begin here in Edmonton. And John, if I can ask you just to repeat the question, and that way everybody can hear it across
Absolutely.
the province. Anyway.
Sounds good. Comments, questions?
So maybe while the shy people in the audience are thinking, I'll take the liberty of asking one, John. So
I'm used to working with students, and I embrace silence, so I wait them out. They sit there, and then someone gets so uncomfortable, they finally ask
avoiding
a question.
eye contact and so on. Yes, we've all been there. So John, thanks again. Great talk, and marvel at how you're able to distill this large body of work in a succinct way. And it's also good to hear from someone outside about how we're doing things here in Alberta. We are blessed with riches in many respects. We don't often think that way, but we do recognize that we are. Are there places in the world that, and one of the struggles is we often don't know what success looks like. So are there places in the world that have really nailed this or really come close to which we could aspire or we could use to help guide us?
Yeah, so I wish that, and so far we haven't done the international scan. So, and it's clear that, the United Kingdom, for example, has done some great work that has parts of this. Verna and I were at a meeting last week where Chris Ham presented some of the lessons learned, but they didn't seem to frame it in this exact way. And in a way, aspects of the messages to me were a bit depressing. He was focused on a lot of the failures and not about how did they learn from the failures to do things better and differently. One of the things that was also depressing for me was he lamented the NHS, the National Health Service in the UK, their fascination with big structural reform, which because we're about to lose the next 2 or 3 years in Ontario to big structural reform, I found a little bit disheartening. His message was, just leave the structures. Just focus on how do you keep making them better and making incremental changes to them. So back to your question, we have not found a good example yet. We've started a 14-country collaboration where we're actually not focused on the health side. We're focused on where is this starting to work well outside health in the broader social space, housing, social services, education. So in a couple of years, we hope we'll have many more good examples from those other areas. But in health, we haven't done that international scan. So we know there's pockets of excellence in the US with Kaiser, other places. We know there's pockets of excellence in the UK, but we haven't yet done a good enough scan to tell you, wow, these are 3 health systems that seem to have really nailed it, especially when you look across the whole health system, which is Alberta Health Services remit. So one thing to do it in Kaiser, kind of a bubble within a very complex US health system, very different to try and do it across an entire jurisdiction. So now let's make them squirm. Oh, there we go. Okay.
Do you want to say more about rapid learning as a concept?
Yep.
Related to that as well, rapid learning is a mechanism for improvement.
Uh-huh.
Is there any other mechanism other than rapid learning?
I hadn't thought about it that way. We decided early on in the work that we would call the whole thing rapid learning and improvement. And the point was we think those two things go very powerfully together, that you're rapidly learning from patients and families about what matters and whether you're heading in the right direction. You're rapidly learning from the data about whether you're heading in the right direction and what new problems you're learning. You're rapidly learning from the evidence about what you might want to try that's been evaluated elsewhere and seems to be promising. You're rapidly learning about which decision supports are getting traction and which are needed. You're rapidly learning about which governance, financial, and delivery arrangements need to align. So it's kind of a way of thinking through each of those characteristics. How can we keep learning and drive improvement? So that's why we kind of link the two together. Some people argued we shouldn't say rapid for this reason about what's rapid depends on the level. But the reason why we ended up keeping it in is if you're a patient and family member, and I'll tell you, to be honest, on the days when I'm a patient or family member, damn the system that can't make tangible improvements that so clearly are needed. So it's part of that kind of pressure. Imagine a world in which we wake up every morning and we know that the different parts of the system have people who are constantly asking, how can we do better? How can we rapidly learn and improve? Sometimes it's big issues for which rapid will be 18 months. Sometimes it's smaller issues for which rapid can be hours and days. But we all need to be part of a solution of incrementally pushing the system to achieve better patient experiences and outcomes for the citizens of the jurisdiction. So that's why we use rapid learning and improvement. There's many ways of thinking about improvement, but this rapid learning across those 7 characteristics to us seemed like the best way to get everybody rowing in the right direction and in directions that are set by patients and families. Yep. Sorry, I forgot to repeat that question. I'll remember this time.
So I'm just thinking about the assets and how you define them.
Yep.
So were they, when you started to do the work, were they accidental? You came upon them? Were they purposeful? And you said, okay, there's this AHS's these assets.
Mm-hmm.
And what is it within their processes that they integrate with each other that has made them a rapid learning system that would demonstrate improved health outcomes? Does that make sense?
Well, let me try and repeat. I'll break it down in pieces. So first, where did we get the idea of the assets? So what we did was we looked at the literature on rapid learning and improvement, and we found that most of it was organized by those rapid learning and improvement cycles, which to us is kind of what's happening in the background, but it wasn't the most helpful way of understanding where is the system in this area. So then we said when we looked at the literature, it seemed that rapid learning systems were characterized by these 7 characteristics. Some definitions emphasize more than others. So you will see at the meeting last week, there was a gentleman from Michigan who to me is very obsessed with characteristic 2, data. You can also go to a meeting where it's only trialists who are only focused on timely research. You can go to meetings where it's only QI people focused on the rapid learning improvement. So we came up with the 7 from the literature as being important. And then we developed a set of prompts looking at that literature, and we iteratively developed it based on what we were seeing in different provinces. So we got through a first wave, and we realized, wow, under data, if I look under data, if I look under data, you'll see a whole set of prompts, some of which we had from the beginning based on what came out of the literature. But others, when we're looking at Alberta, we think, oh, wow, look at all the data infrastructure that Alberta has. Look at, Alberta's very focused on patient-reported experiences. New Brunswick's focused on longitudinal data. So we started to build up the prompts that would give us a sense of what are all of the types of assets that you would find related to that characteristic. So it was a combination of the literature and iterative development based on what we were finding in the field. So that's the asset piece. Your other question was about the connections and whether it has an impact. There's not actually great evidence yet that people that follow rapid learning and improvement get better impacts. It's just typically not been evaluated. Most of the literature is back at the level of description of the characteristics and so on, not at the impact level. And this is very hard to imagine coming up with evaluation designs, but I can imagine noodling our way towards it over the coming years. But on the connection side, we asked people for their examples of where they thought the connections had been well made. So we didn't have any preconceived notion. We just asked every single person, give us examples of where in your jurisdiction assets have been powerfully connected, and then those are the ones that we documented. Make sense?
One more
Thanks.
question from here. Mark? John, you alluded to Northern Ontario having perhaps more in common with parts of Alberta than Southern Ontario.
Yep.
So did you get with some of the other, so every province has rural and remote areas or smaller jurisdictions. Did you find anything that they were doing in those contexts in terms of the types of assets that were more effective in those contexts that emerged in terms of signals with your review versus the more larger urban
Yeah, so the question, the point was that I alluded to the fact that Northern Ontario would share more with big parts of Alberta than it would share with Southern Ontario. And the question was, did we find anything in the assets and so on that were particular to those environments? I would say the answer is no, but what I would say is that many of the interviewees pointed out that a big challenge in their jurisdiction was less about the existence of the assets and more about the distribution of those assets. And their worry was that in some sectors, like primary care, in some regions, like our rural and remote communities, those assets aren't available. They're unlikely to be available in the short to medium term, and we need to figure out a mechanism that people in those environments can reach in to where those assets exist and somehow be able to make use of them. We have to come up with a way that they can access them. So no one that we found had a model for how that could work. But again, I'm back to that, it's not rocket science. You could imagine a way to support people in those currently underserved sectors, populations, conditions, and so on to help them out.
Maybe I'll just check in with Sean, and then we'll come back to Edmonton. Sean, anybody?
Sure, yeah. We've got one question you kind of spoke to a little bit earlier. One from Calgary is asking, what do you find to be some of the biggest barriers to rapid learning, whether at frontline staff level or at the larger system level?
So the question was, what do we find is the biggest challenge to rapid learning, either at the frontline level or the system level? I know the latter better, and I know what we are seeing the struggles happening with are the connections piece. People recognize many assets and they don't know how to make the connections. So we've got all these great data. We have these researchers who can do this. We've got the government financial delivery arrangement levers, but we cannot connect them. And that's working within a particular sector or whatever. And the second big issue that we're increasingly encountering is people don't know how to join up these rapid learning and improvement groups across sectors and so on. So in Ontario, we have this dialogue coming up at the end of March, where we're bringing together all the key players, the rapid learning and improvement people from cancer, the ones that do high-level strategic policy, the folks who are focused on people living with HIV, and we're getting them all in a room to say, all of you are doing amazing work. Some of you have innovations others can learn from. How do we get you learning from each other? But also, how do we knit this together into a better kind of whole? How do we make the whole, what's the expression? The whole greater, the sum greater, the whole greater than the sum of the parts. So that's a big question, is how do you connect the assets, and then how do you get people talking across these micro rapid learning and improvement areas? So those have been the big barriers. People, as I said before, I have never encountered an approach that gets such widespread buy-in. Public servants tend to love this as long as it's explained in the right way. Politicians get it, patients and families get it, but people are struggling with how to join things up in ways that work in this particular way. Frontline improvement, again, I would probably not be the best person to ask. In our world of Ontario, the group that's farthest along on that front is an Albertan from Edmonton, Rob Reed, who some of you will know, who was here, was in BC, went to Puget Sound, now is setting up a rapid learning regional health system for Mississauga, just west of Toronto. 40 folks, all focused on how do you operationalize this at that frontline patient care level. So if anyone wants concrete examples, probably our one jewel in the crown in Ontario, I would point you to Rob. You have many jewels in the crown. We have one, and he's an Albertan.
Sean, any other questions?
I think that question actually answered a couple others, but I had one myself.
Okay.
Earlier you mentioned about accreditation and a lack of standards in terms of rapid learning framework.
Yeah.
Do you know if there's been any discussions with Accreditation Canada to adopt such a standard?
Not that I'm aware of. So I was asked that question this morning, and I said not that I'm aware of, but I co-chair an advisory committee with the head of Accreditation Canada, so it's on my agenda to catch her and to speak about this. To me, it would be just hugely helpful. Like, imagine a world where you have these different sites, you have, different groups that they go through a process of documenting their strengths in this area, coming up with plans to improve them. So to me, accreditation is a very powerful way to think about how to institutionalize this in our health system, but to my knowledge, it's not gotten traction yet.
Good. We'll come back in.
Hi, I have a question around the data analytics and the role that might play in
Yeah.
identifying the problem itself.
Mhm.
So when you're looking at the health system as a whole or specific areas of focus, is there a role for predictive analytics to identify the question and identify some problem areas?
Yeah, we're on the cusp of this big data revolution. At this point, it's wildly overpromising and under-delivering, but it will flip at some point where we start to deliver. My hope, though, is the rapid learning system stuff forces people's attention on making those data usable by patients and families, frontline providers, organizations, and so on. But when you look under the hood, AI, artificial intelligence, all kinds of predictive stuff, that's almost certainly going to be part of it. But my worry is less that we won't get there on that front, it's that we won't get there on the plain language information that is usable in decision making. So I think we absolutely want to connect to those new areas, but we need to keep our eye on the prize that in the short to medium and long term, what matters is can we present usable information to people. The other quick comment, which is more about artificial intelligence, so it's a slight segue, but there was a meeting recently, a national meeting about the role of artificial intelligence in rapid learning and improvement. And the kind of insight for me was that for regular decision making, AI is not going to be that helpful. What's going to be really helpful is looking for patterns in data in complex areas like multiple drug interactions on the intervention side or multimorbidity on the condition side. What outcomes do we see happening for someone living with 3, 4, or 5 discordant health conditions, and what types of things seem to matter? In primary care, that could be revolutionary in the long run because much of primary care are people living with multimorbidity. And if we treated each person to the guideline for each of the 5 conditions we have, we'd kill them. So how do we figure out which goals are most important and which interventions will help people achieve their goals? And so at this conference, the AI folks were saying that's the type of thing where AI could actually have some breakthroughs because analytically it's too complex for us to figure it out, but AI could help to see patterns in those data.
Sean, last check came with other sites?
There's one more, and I apologize, I'm not sure I can capture your thoughts exactly, but like involving patients in setting the dial, what are your thoughts in involving frontline staff in identifying targets so health information systems can collect and report information that's relevant and useful in a day-to-day fashion?
Yeah, so I guess in a way there's 2 points to the question there. Alberta Health Services has done what I think makes a lot of sense, which is orient to the quadruple aim that says, we're trying to improve patient experiences, we're trying to improve population health, but we're trying to keep costs manageable, and we want to make sure our providers are happy and content. So to me, the first part of the question is about, yes, patients need to be helping us pick the dials and pick where the needle is, but obviously providers need to be in on that conversation too, and they're part of that kind of participatory engagement mechanism that's going to be absolutely key. And then the second thing, now I forgot what the second thing was that I was going to say. Patient and provider, about the data piece.
Yes.
Yeah. So, the data piece I think is absolutely essential. We are awash in data, and in a very short period of time, we're going to be drowning in data with Connect Care on the one hand, wow, so much potential, but on the other hand, that if we don't turn it around and ask ourselves, what's it going to be like as a primary care physician receiving all of this stuff, and how can you give me usable information that will help me engage in rapid learning and improvement to help my patients? So I think providers have to be at that table from the very beginning about trying to figure out for the information that's going to flow to them, what form and so on is going to help them engage in better decision making. So, and that's going to be true of patients and families too as another target audience, but they have to be front and center. I was saying in an earlier meeting that in Ontario, we have something like, I can never remember, it's 21 or 22 sites that you can go to get a health system performance data relevant to primary care. That's completely crazy. It's completely untenable as a primary care physician. It's untenable as a patient and family member. We need to flip it around and say, imagine you're a primary care physician, part of a network. What types of data on what terms and how do you want to be able to access that information in ways that will be tangibly useful to you? And if it's not useful, then leave it in the background, let AI figure it out. But we have to figure out how to get plain language information out of these rich data if it's going to be part of rapid learning and improvement.
Any other questions here yet? If not, a couple of comments in closing. So first of all, to our audience, thank you very much for your attendance today, both here in Edmonton and across the province. If you've really enjoyed Dr. Lavis's talk and you want to see it again, or if you want to recommend it to friends and colleagues, you can find it by searching on Insight at PSS, search PSS, and it should come up.
It's usually online about a week after the event.
Very good. Thanks, Sean. And then finally, John, I'd like to thank you so much
My
for
pleasure.
coming
Thanks for
to
having me.
Alberta and helping inform our continued journey, and for your work in Canada to help us improve our health system.
My
Thanks very
pleasure.
much.
Thanks for having me. Thank you very much.
For you.
Thanks, everybody.